Welcome back to the Ninja Nerd Podcast. Today we've got a great new episode for you on antiplatelets, anticoagulants, and thrombolytics. We've got several different cases we're going to go through, and hopefully we can crack the case and figure out what's going on.
Yeah, man. Got to figure out what kind of blood thinner they're taking, as you'd say. You know, that's a common layman's term.
That's probably what I would say. Blood thinner.
And then kind of just go from there. Say, okay, which one is this likely that they need? And then kind of why would I do this one? And kind of the follow-up questions that we'll have. So just a heads up, sorry again for my voice. I got the cold and I apologize. My nephew, bag of germs, just passed it right on to me, but hopefully I'm getting over the hump and stuff.
So the kids, when they go to their daycare, it's just it's a super expensive place to just get sick.
Yeah, just bring it on. You know, and he comes over, he coughs right in your face. I was like, well, it's over. I'm going to get the cold.
Yep. Same with my nephews. Same thing. Yep. It's tough, but hey, they're kids.
Gotta let them be kids.
All right. Well, we have case one. Let's just jump right on in. All right. We have a 55-year-old male presents to the ED with chest pain radiating down his left arm. The patient reports chest tightness lasting 30 minutes. He has a history of hypertension, hyperlipidemia, and diabetes. He denies prior coronary artery disease or GI issues. His father had an MI at age 60. For his exam, vitals, BP 145/85. Heart rate is 88, respirations are 18, temp 98.6, and his O2 sat is 95% room air. Cardiovascular, normal S1, S2, no murmurs or rubs, and then pulmonary is clear to auscultation bilaterally. Lab findings, troponin is elevated. In his ECG, we have ST elevation and leads 2, 3 in AVF. That's an inferior MI.
That's right, baby. Dude, you're the man.
We're learning. I'm learning.
Yeah, that's cool.
Hey, I'm learning. I am learning with when I do these cases with you guys.
And that's what I love.
I'm learning too.
I know. That's what I love, man. Seriously, that's super cool.
So something's working.
We're getting in there.
Couple questions for you for our discussion today.
Okay.
Question one. Why is aspirin given immediately in this scenario, and what is the dose?
Yeah, so you know how they always say for all the boards it's MONA?
Yes, MONA. I learned that too.
Yeah, morphine, oxygen, nitroglycerin, and aspirin. Those are, cool, but the only one that will truly make a difference and change mortality is aspirin. All the other ones are kind of just like symptoms, like morphine you give for chest pain. And usually it's actually a bad sign. If you have to give morphine for someone who's in chest pain and it's the only thing that's really working, kind of may have a poor prognostic kind of indicator.
Okay.
Oxygen you really only give if they're hypoxic. And nitroglycerin is, again, it's more for chest pain. It's supposed to help to kind of really dilate those coronary vessels and reduce the preload and the stress on the heart. But aspirin's the only one that really is good in this scenario. And if you think about why, when a patient develops an acute coronary syndrome, which we have three types, unstable angina, right? Okay. NSTEMI, and then a STEMI.
Okay.
So out of all of those, generally what happens is there's a coronary plaque to some degree in some patients. This patient is 55.
Yeah.
So probably over time, they've developed some plaques. They have a history of hypertension, hyperlipidemia, and diabetes.
Sure.
All of those things are harbingers for developing atherosclerosis. That plaque ruptures. When it ruptures, platelets will stick to it. When platelets stick to it, they start kind of forming a clot on top of that plaque, or thrombosis. And basically the amount of plaque or thrombosis that they form, depending upon the severity of it, reduces the flow around that thrombus. So in unstable angina and STEMI, the clot's not completely occluding the circulation, and so they may get some blood flow in there, maybe 20, maybe 30%. But for STEMI, that's almost a complete occlusion. So you're almost getting no blood flow. So unstable angina, you're getting a point where you're kind of getting very poor perfusion, but it's not enough to where you're actually causing myocardial death. And so you don't really see a troponin spike, but you may see some ST changes. For NSTEMI, you actually get some myocardial death, but it's usually the deeper layers. So you get a troponin spike and you get ST depressions. When you have this, ST elevations and a troponin spike, that's almost a complete transmural infarct, and for the inferior wall. So in that scenario, I have a pretty good clot. Yeah. And the job of aspirin here is to try to prevent the clot from continuing to form, because it's not going to bust up a clot. It's not going to do anything to say, okay, let me break down the clot. All it's going to do is it's going to inhibit a cytokine called thromboxane A2 from being formed. And what that does is that prevents other platelets that are circulating through from coming in and sticking to it. All I want to do is make that platelet plug not get any bigger. I don't want to include more of the lumen. That's the whole goal. So we'll hit them with about a 325 milligram slug of aspirin right off the get-go. And that's not the only thing that you usually have to do in these patients. You have to oftentimes load them up with other things. So for this patient, I'd load them up with aspirin. I'd probably give them a clopidogrel load of 300 milligrams. I'd give them a heparin load. And then on top of that, I would take them to the cath lab.
Briefly, just explain what each of those medications would do. We know aspirin, we know the mechanism. What about the other ones you just mentioned?
So aspirin and clopidogrel, they're kind of antiplatelets in combination. So what I mean is aspirin inhibits thromboxane A2 production from platelets, so they prevent other platelets from coming and sticking. P2Y12 blockers, which is clopidogrel, ticagrelor, prasugrel, those actually block ADP, which is another cytokine that's made by platelets that tells other platelets, hey, come and bind. It blocks that ADP from being able to tell the platelet, hey, come over and bind to this other clot where these platelets are. So that's kind of the design. And then heparin, it's interesting in the sense that heparin actually inhibits the coagulation cascade. So it has nothing to really do with platelets. So what it actually does is it enhances a protein called antithrombin 3, and then antithrombin 3 inhibits thrombin and what's called factor 10. And so you inhibit formation of what's called the fibrin mesh. And so the fibrin mesh forms like that big kind of like secondary kind of clot on top of the platelets. So that's what you're doing, is you're really trying to just prevent the clots from getting any bigger so that you can get them to the cath lab and pull that clot out.
And then heparin really is more so exerting its effect on the intrinsic pathway.
Yeah, dude, you're the man.
All right. Hey, you watch these podcasts, you're going to learn something.
Yeah, that's the cool thing, man. Yep, exactly. So that's the whole concept, is they hit the antiplatelets with the aspirin and clopidogrel, the dual antiplatelet therapy, as you could say, and then on top of that, you hit them with heparin, and that's going to hit the coagulation cascade. All of these things are going to try to just prevent the clot from getting any bigger.
Now, I know we'll get to this in a little while, but what about the actual clot buster?
Yeah, so, and a lot of times you think, oh man, TPA would be great, right? Like a thrombolytic of sorts.
Sure.
Not really great in STEMIs. So the evidence has shown that they have poor performance in comparison to actually going in and snaking a catheter up through the coronaries and removing the clot itself. So getting a percutaneous coronary intervention with potentially a stent and maybe a balloon and a stent placement, it's way superior. You can still do thrombolytics if you're at a facility that doesn't have it available, but we don't prefer it. It's not the first line. So You'll do it if you have no other choice, but TPA is not going to be the best one.
So for this patient, perfect example of having them go to a cath lab.
Yeah, if I can, I'd do that. If I have no other choice and I have to give them TPA, I'd give them TPA, but I would still send them to a cath lab if I could. Yeah.
Okay. All right. What is the role of aspirin in atherosclerotic cardiovascular disease prevention, and how does it differ between primary and secondary prevention?
That's good. I like that. So generally, it used to be back in the day that like patient has they're older. You just they're greater than 50 years of age and stuff like that. You just take aspirin. Right. We don't really follow that scheme anymore, really. And so your desire is to try to determine which patients really should get aspirin based upon a risk. And so a lot of the times what we will do is the times where we'll start aspirin is if they have clinical atherosclerotic cardiovascular disease. And what that means is they had a history of some kind of an event. So that they have like PAD and they're having claudication and they've had episodes of limb ischemia. I should definitely give them aspirin then. I don't want those clots to get bigger. Coronary artery disease, if they've had a history of an MI, like this patient going forward, I would put them on aspirin. I'd keep them on aspirin. I would do a lower dose, but I would keep them on aspirin. And then if a patient had a stroke, and that stroke is due to atherosclerosis, I would give them aspirin. If the stroke was due to something else, though, not due to atherosclerosis, then I would treat that. But basically, the concept here is if a patient has atherosclerosis and they've had cardiovascular events because of it, give them aspirin so that you prevent them from developing those events in the future. So secondary prevention is really the way to go. We don't really do as much of this primary prevention. The only time where you'll do primary prevention is if they have a high risk. And what that means is there's all these calculators out there. I want to say it's called the Framingham risk assessment, but you get this calculator. You can look on MD Calc, and you plug in all the patient's information, and it gives you a risk, like a percentage. And so those patients who have an atherosclerotic cardiovascular disease risk of over 10 years of greater than or equal to 7.5%, you could make a decision with them together and say, hey, I think you're at risk for cardiovascular events given these particular findings. You have high blood pressure, you have diabetes, you have et cetera. In those scenarios, I could talk with the patient and say, hey, I really think you should be on aspirin. Are you okay with that? Because I don't want you to develop atherosclerotic cardiovascular disease events. So secondaries, they developed it. You just want to prevent further events. Primaries, you're trying to say, hey, I don't want you to get any of these events. Can I start you on this? And that's kind of a shared discussion per se.
Okay, got it. Why is aspirin contraindicated in children? Because I've heard that if they're less than 18 or I think it's less than 19,
Yep.
you're contraindicated with a viral infection.
Yeah.
What is that? What's that condition called?
The Reye syndrome.
Okay.
Yeah, so you got to be careful. Generally, try to always stay away from aspirin in this scenario. Try things like Tylenol, obviously, first for a viral infection. They have pain and fevers and things like that. But because aspirin is an antipyretic and it's an anti-inflammatory, so it has that property because it kind of acts like pretty much like an NSAID. It has those properties to be able to do that. But concept here is that aspirin, when there's a viral infection somehow in the liver in a child, they alter the metabolism of aspirin somehow, and it gets these toxic metabolites, which is weird. They cause liver damage, so then your hepatocytes start to die. If the hepatocytes start to die, you no longer have the ability to clear things like ammonia, and so ammonia can start to build up, and if it builds up, it can cause hyperammonemia, and then that can cause things like cerebral edema, and so that, kids can get super confused. They can get cerebral edema that can cause high intracranial pressure, headaches, etc. So that's one big thing. But the other thing is that it can also impair the liver's ability to make coagulation proteins, and so they can get coagulopathies. So you really want to be careful of that, watching out for hepatic encephalopathy and hepatic coagulopathy, and then just deranged liver enzymes. They'll have increased LFTs, and so those are things to watch out for with Reye syndrome. Is they come in, had a virus, oh, they're having a fever, and then what do? Oh, let me give aspirin. It's an antipyretic. They'll do that. Unfortunately, as a result, they'll end up with potentially Reye syndrome, which is a characteristic of hepatic encephalopathy and hepatic coagulopathy.
Yeah, that really is pretty devastating.
Yeah, exactly.
How about this one? What are the strategies to reverse bleeding due to aspirin use?
So my working in a neuro ICU, you see this a lot where most patients in a neuro ICU, they're on aspirin.
Yep.
And then sometimes they'll come in with a bleed in their brain, right? Or they're going to get a neurosurgical procedure. And there's always this constant back and forth and debate between neurosurgical colleagues and other critical care colleagues. Hey, patient came in with a bleed. I'm going to put an EVD in. I'm going to have to do surgery. They took aspirin. I'm going to go ahead and we should reverse that. There's not a lot of good guidelines on that. And so oftentimes we don't really reverse aspirin in the sense that when we say reverse, it kind of, the only really true thing that you could do is platelet transfusions. And so I think it depends upon the patient. If they have a very devastating bleed, I still wouldn't really push to reverse aspirin because in the sense of giving them a platelet transfusion. Maybe the only time where it could be considered is if they're getting a neurosurgical procedure. Otherwise, we don't really give platelet transfusions for aspirin because when you give the platelet transfusion, the aspirin's still going to be lingering around. So it's still going to kind of inhibit these effects of the platelets doing their job. So that's why really giving platelet transfusions or DDAVP and things like that, they really don't have any strong bearing to be reversed in true clinical scenarios.
But there's no actual direct reversal agent that exists.
No, nothing specific, nothing for aspirin, nothing for P2Y12 blockers, nothing for the GP2B3A inhibitors, which we'll probably talk about a little bit later too. All of them, we don't really have any specific reversal agents if we need to do anything, particularly if they have a devastating bleed or they're getting a procedure that makes them super high risk, we may give them a transfusion. But
okay.
Yeah, DDAVP is another one that they throw out there. Again, I've never really seen these used, but DDAVP is another one that you could consider, just so you guys know, for aspirin, because it kind of increases the production of von Willebrand factor, and so it may help your platelets to stick a little bit better.
Okay. All right, enough said. Let's move into case 2.
Okay.
We have a 62-year-old male presenting for follow-up after PCI with stent placement. The patient underwent PCI with DES for STEMI 2 weeks ago. He was loaded with clopidogrel, 600 milligrams, prior to the procedure and started on DAPT afterward. He now expresses concerns about medication effectiveness and bleeding risk. For his exam, we have vitals. BP is 130/80. Heart rate is 78. Respiration 16. For his cardio exam, normal. S1, S2, normal. No murmurs or rubs. Lab findings. We have a CYP2C19 genotype. Jesus, man. What on earth is that?
Yeah, so some people, clopidogrel is metabolized by the liver. So it's kind of in a prodrug form and has to be converted into its active form, so it has to go through the liver. And so CYP2C19, which is a cytochrome P450 enzyme, is needed for this to happen. And so in some patients, they may have the very hyperactivity of this enzyme. And so what that means is if their enzyme is really, really good, they'll easily convert clopidogrel into this form. And in some people, they may not be a good metabolizer of clopidogrel, and they may not convert that clopidogrel into the active form as well. And so it kind of depends. So depending upon the activity of that enzyme, if they're a hyper responder, under responder, determines kind of how well that drug will work. And so we like to actually consider this in people who are on clopidogrel, and let's say that they're on clopidogrel and they develop clots despite that, and it's because of their atherosclerosis, we should start questioning, why the heck is this happening? And you can actually check the activity of clopidogrel by checking what it actually blocks, which is a P2Y12 level. And it kind of tells us, are they a hyper responder or a under responder? And then it may tell us, oh, we should probably pick a different drug.
So to clarify, we all have this genotype.
Yeah.
We all have it, but maybe in this patient, for example, would he be considered on the poorer end of it?
Yeah, and so that's the whole concept here, is that in this scenario, if you have like people who are like poor metabolizers, then you probably may need to pick a different drug. And so that would be a really good example of this, where it just tells me it's probably not one where clopidogrel is working very well, and I may need to pick another one that doesn't have this much of this dependency of this enzyme, and that's usually where ticagrelor comes into play, because it doesn't really have to go through this pathway.
So just to save the debate here, this patient will say is a poor metabolizer. You would then change that drug regimen.
And I would really, and the only way I could truly tell that is I would have to check what's called a P2Y12 level.
Okay.
And then if my P2Y12 level came back like pretty high, it tells me he's not going to be a good responder to it, and I should switch him to something else.
All right. Well, then let's get into the discussion, because I definitely wanted to ask about the P2Y12.
All right, cool.
So what is the role of a P2Y12 receptor antagonist in stent placement?
All right, so let's say that we have this patient here. As they said, he went to PCI, which is a percutaneous intervention, with DES, so drug-eluting stent, for a STEMI that they had 2 weeks ago. So when you get a STEMI, we already hit, you give them 325 of aspirin, you load them up with clopidogrel, and then you give them IV heparin, send them to the cath lab, they'll go in, pull the clot out, and then they may stent open that vessel. Especially if there's a lot of plaque, they may kind of balloon it and then put in a stent. When you put in a stent, you dedicate the patient to dual antiplatelet therapy for at least a year.
Okay.
All right. The concept here is that the stent needs to endothelialize. You need to form a good endothelial layer over the stent, because if you don't, you could clot off that stent. If I clot off a stent, I'm going to end up with a really bad infarct into that same territory. So that's the whole point, is preventing that stent thrombosis is the big indication of why I'd add on like a P2Y12 blocker for 2 aspirin for at least 12 months. So how it really kind of works, is we kind of hit on this a little bit, is that you give clopidogrel, ticagrelor, prasugrel, those are the common ones. Mm-hmm. Give them, they bind onto a receptor called the P2Y12 receptor. And that's why we check P2Y12 levels. You bind onto that receptor, and then ADP, which is coming from another platelet, is supposed to bind onto that and kind of activate the platelet. Well, you give these drugs, it prevents ADP from binding, and then therefore the platelet won't be able to become activated and stick to the other platelets. So that's the concept and how we actually do this. But again, kind of for stent indications, it's always, when you get a stent, you dedicate them to what we call DAPT, dual antiplatelet therapy, which is aspirin, usually 81 milligrams, and then a antiplatelet of your choice for a P2Y12. I prefer ticagrelor. That's becoming more of the beneficial one nowadays, but ticagrelor, or Brilinta is the name of it, that would be one that I would reach for. Clopidogrel is another one, but I would be very careful. If I put them on clopidogrel, I would check a P2Y12 level just to make sure that they're a good responder.
As far as an antiplatelet goes, if you're choosing, and you said ticagrelor, you would go toward, what would really be considered the first line?
Often people go to clopidogrel.
Okay.
Yeah, it's usually.
But that might be changing a little bit?
It kind of depends. I think it's provider preference.
Okay.
So I think like some people, they're probably like, clopidogrel also can kind of have interactions with other drugs too, because it does go through that cytochrome P450 system. Ticagrelor is great because it doesn't have to go through that kind of CYP2C19.
Yeah.
So, but it does carry other risks, maybe a little bit higher bleeding risk maybe. There is other things like can cause dyspnea and stuff like that too, but I think it's a great drug, and it was something I would probably reach for over clopidogrel to just bypass that cytochrome system.
How about prasugrel?
Prasugrel is a good one, but it's kind of a black box warning because it'll have the highest bleeding risk.
Oh, wow, okay.
Yeah, so out of all of them, I'd say it's probably a little bit higher bleeding risk.
So you might avoid that one if you could?
Yeah, it's a really good one, but I probably would say I'm not going to go to this one first. I'd probably go to ticagrelor or clopidogrel.
Understood.
Yeah.
what complications may occur with rare use P2Y12 receptor antagonists such as Ticlopidine, and how is it monitored?
Yeah, we don't use that drug no more. Thank goodness.
Why is that?
Because it can cause TTP.
Oh.
Yeah.
You don't want that.
No, you don't want that. Funny enough, it's a terrible drug, but Ticlopidine was an older generation, so we don't use it as much anymore since, thank goodness, we came out with Clopidogrel and Prasugrel and Ticagrelor. But that one was older generation, so what happened is that could actually cause TTP. So it could cause like an immune response. So you develop antibodies against it. They would attack your ADAMTS13 enzyme. That thing's frecked. It doesn't work, can't break down von Willebrand factor. And so that builds up. Platelets start sticking to one another. You get clots. And then you end up with anemia because you rip up the red cells as they run through it. You end up with clots in the brain. So you can end up with neurological manifestations. Clots in the kidney. You can get like renal failure. So it's a pretty nasty one. But on top of that, you know what else it does? If it fracks up your bone marrow, it could actually suppress the bone marrow, I think, as well. So you can get like leukopenia, neutropenia, and anemia. So
it's like you're trying to the effect you're trying to achieve, you're doing the complete opposite of.
Yeah, exactly. Yeah, so your whole goal is try to just never. We don't use those anymore, thank goodness. But that's a good board exam question. They love that one, even though it's not used. It's like, oh, let's come up with a thing that can really stump the student that we don't ever use anymore.
Yeah, just know that we're not using that.
Yeah, but I think the hallmark kind of like pathognomonic thing or high yield thing is Ticlopidine. TTP is a big association, and why we try to stay away from it.
All right, case 3.
All right, let's do it.
We have a 70-year-old female presenting with a STEMI.
All right.
The patient was loaded with aspirin and ticagrelor in the ambulance. During PCI, a high thrombus burden prompted the use of a GP2B3A inhibitor. For her exam, we have vitals. BP is 110/70, heart rate is 92, respirations 18. For her cardio exam, we do have a normal S1, S2, no murmurs or rubs. Just a couple questions, Zach. What are the indications for a GP2B3A inhibitor in acute coronary syndrome?
Yeah, so I don't really work in interventional radiology as much, but dealing with them through some of my patients, they love to use this one a lot. The concept behind this one is, let's say that you have a patient comes into the ER, they have a STEMI, like this patient, they get hit with aspirin and clopidogrel and heparin or something like that. That's your usual. Let's say for whatever reason they go to the cath lab, they look, and there's a big fracking clot somewhere, like in like the left anterior descending artery or something like that, and it's causing like left ventricular dysfunction in this patient. You're starting to see some complications from that, like pulmonary edema. Sometimes that's when they'll reach for it. So they'll give this drug because it's really, really good. It's kind of it's one of the, out of all the antiplatelets, is the strongest. But it has a higher bleeding risk. But the other reason I've only ever seen it used is, I'd say 2 indications. They go to the cath lab, and they go in, they load them up with all this stuff. They go in, and then what happens is when they get in there and they kind of pull that clot out, they don't have good flow. So there's still some residual clot in there. They'll nail them with an IV. This is IV. These are only IV drugs. Okay. So they have super rapid and fast onset. So you can nail them with a good slug of like one of these medications. I see often eptifibatide used. I've never seen abciximab used. And tirofiban, I haven't seen that one. So the most common one I've seen is eptifibatide, also known as integralin. And those are often given as kind of like boluses and sometimes drips too, because they're going to go in there, going to really help whenever there's what we say a poor reflow. So you go through, you cath them, you pull out the clot, and there's not a good reflow. That would be one indication. The second one is a bailout therapy. So let's say that they're going in and someone didn't load them up with clopidogrel and the ED, or they didn't have enough time, or they just gave it to them, and these oral medications, they take a while. Well, then I would give one of these medications because they're going to be rapid acting and they're going to give me immediate onset. And sometimes I'll do that if I really need help trying to kind of they'll give this medication if they really need help trying to get this clot to kind of go away and to really help them to pull that clot out. So I'd say bailout therapy is a big one of why they would do that. Poor reflow after pulling the clot out, and then they just got a huge clot like burden. And they're like, okay, we're really going to need this to prevent the continuous clot propagation. That would be kind of the big indications.
To make sure I understand, this isn't always done every time.
No.
This is just for those scenarios that you talked about.
Yeah, I'd say bailout, poor reflow, and certain scenarios where they're like super high risk and they got a big clot burden.
So using it when you really need to.
Yeah, and you don't continue it afterwards. And so like it's only really, it's IV. And so you're only ever going to be really doing it in the interventional radiology kind of like suite when you're kind of having these patients in there and you're like, oh, dude, they didn't get their load in the ED. All right, give them Integralin or eptifibatide, give them a bolus of that. They're in there and they're like, oh, man, I can't get this clot. I'm not getting a good reflow. Give them a bolus of eptifibatide, or I need to get some better kind of control here because they have so much clot burden. Give them a bolus of eptifibatide. After that, you don't really continue these long term. So they're really only kind of like emergent kind of interventional use.
Are there any other examples of drugs?
I'd say the biggest one is abciximab. I haven't seen that one used. Tyrofibin is another one, and then eptifibatide. That's the most common one I've seen used.
And then always administered via IV.
Yeah. So that's why they're rapid and they're not really long term. They're more short term.
Okay.
Usually, I think the biggest way to remember it is high risk patients. It's usually add on to everything else: the aspirin, the clopidogrel, and then the heparin. And it's just you add this on in certain scenarios.
Okay. All right. Well, that one wraps up case 3. Let's move into case 4 now.
All right.
We have a 50-year-old male presenting with chest pain and dyspnea. The patient is on heparin for NSTEMI and now reports new chest discomfort and the shortness of breath.
Okay.
For his exam, vitals BP 125 over 85, heart rate is 92, respiration is 18. We note on his extremities there's right leg swelling. Lab findings, PTTs prolonged, platelets 60,000. It dropped from 160,000, and PF4 antibody is positive. What are the differences in monitoring unfractionated heparin versus low molecular weight heparin?
Yeah, so this person on NSTEMI, which they probably got the aspirin, the clopidogrel, and the heparin, and they're probably just monitoring because they didn't go to PCI for any kind of like need there. And you don't always have to. But then after that, they develop new chest discomfort, dyspnea, and they have a DVT. So the question is did they develop a DVT because of heparin, or is there something else kind of happening here? But the big thing here is oftentimes when a patient comes into the hospital, the easier one to give in true reality, because the nurses don't have to, you don't have to get a central line or a pick, and the nurses don't have to go and get blood draws like every so many hours, is low molecular weight heparin. It's a twice daily dose, sub-Q injection, and it's great. And it's weight-based. So those are, I'd say it's pretty popular, and you don't have to really monitor anything for that one. I'd say if they're like really chunky, like me, or they got like bad kidneys because it's renally excreted, then you might have to monitor an anti-XA level, but it's my preferred. It's just once you give it, it's there. So, there's no like stopping it once you've administered it. Unfractionated heparin is very short half-life. And so because of that, it makes it very desirable for titration, so as an infusion. And so when you give unfractionated heparin, the thing that you have to do here is you have to monitor their PTT a lot. And there's newer protocols that are saying to monitor anti-XA levels as well. But nonetheless, that one requires very close monitoring because it's a short half-life. But the benefit of that one is if they develop any kind of issue, you can just stop it.
Yeah.
And so that's the nice point about that drug. But again, it kind of just depends upon the patient. Unfractionated heparin over low molecular weight heparin carries a higher risk of HIT, which is what I think this patient has. I think they have heparin-induced thrombocytopenia because they got, I think, a DVT. Maybe that's a result of the heparin, funny enough, which is paradoxical. And then they have a platelets that have dropped, so thrombocytopenia. They have heparin use most recently. And then on top of that, somebody got a PF4 antibody, which is cool, and that's positive. That's pretty much almost like likely of HIT. So I'd say that, they're probably taking unfractionated heparin. They developed an unfortunate complication from taking that heparin, which is thrombosis, and thrombocytopenia, which is the HIT diagnosis.
Are there any other things that you're looking for that really make you think HIT?
I'd say the biggest thing is if I see thrombocytopenia, that's the first one. And then I like to see greater than a 50% drop. So 160, oh yeah.
So we have that.
Yeah, greater than or equal to 50% drop, like within 5 to 15 days, boom. Heparin use within 5 to 15 days. And then what else is there? Thrombosis, right leg swelling, the DVT.
Yep.
And then on top of that, the somewhat of a, it's not the gold standard diagnostic test, but it's at least a start. PF4 antibodies that are positive, if you got a high titer, that's pretty much good. And then I would send off a serotonin release assay. Problem is in true clinical reality, serotonin release assays take a while to come back. They're a send out lab. And so if I send that out, I'm not going to get that back anytime soon. So I'm going to treat them regardless if I have a high degree of suspicion.
So what do you do then if we're worried about if we're heparin-induced thrombocytopenia? What's next?
Yeah, so this patient's now got a DVT, and on top of that, I got to treat their NSTEMI, right? So they have to be on anticoagulation,
right?
So I got to put them on something else. The workaround here is to give direct thrombin inhibitors like argatroban, because you got to give IV. You kind of want to stay away from right now, stay away from PO. So dabigatran would not be a good one. So I'd go with what's argatroban, which is an IV drug. I've never used bivalirudin, but that's another one that you can consider.
So you're immediately stopping heparin and you're going right to argatroban or
bivalirudin.
Okay.
Yeah. But I've never used that one. Argatroban I've used once. I've only seen hit once. But yeah, in that scenario, if I have a high degree of suspicion, you stop the heparin, start argatroban, and then you can monitor argatroban with PTT levels too. So if you want to see that, to see how it's not commonly monitored, but argatroban, you can monitor PTT levels to see how it's doing.
Okay. What would be the reversal agent if we are using unfractionated heparin and bleeding?
So I would give protamine sulfate. Protamine sulfate I've only had to give like twice. A massive intracranial bleed is a pretty good reason to give protamine sulfate to reverse the effects of heparin so it doesn't get any bigger. And then the second one was a patient who went into hemorrhagic shock. They unfortunately developed an RP bleed. They were on heparin. And then we had to reverse the heparin as well as a massive transfusion protocol. But those are the biggest reasons I'd say is hemorrhagic shock, a massive bleed, like a big GI bleed, a massive intracranial bleed, something that's causing like high potential mortality. Reverse the heparin with that drug.
Is heparin-induced thrombocytopenia very common or is it fairly rare?
I'd say it's fairly rare. Yeah, I wouldn't. I oftentimes when you're in the ICU and you see thrombocytopenia, you should think HIT. It should be the first thing that you think of. But we use different scores. 4T score is the gold standard of determining a chance. Like if a 4T score, when you throw it into MD Calc, is greater than 4, you should have a high degree of suspicion. You should probably go ahead and order the antibody testing and the release assay, but then stop the heparin and switch them over in the meantime.
Okay, let's keep moving here. We got case 5. We're almost done. We're getting there.
We're cruising.
We have a 72-year-old male presenting with hematuria and an INR of 4.5. The patient is on warfarin for a mechanical mitral valve. He was recently started on trimethoprim sulfamethoxazole for a UTI. Couple questions for you.
All right.
Why was warfarin chosen here over a DOAC in this patient?
Oh, that's a good question. So DOACs are your direct oral anticoagulants, and that's your direct factor 10A inhibitors, like apixaban or rivaroxaban, super common drugs nowadays. And then direct thrombin inhibitors. I have dabigatran, I've never seen it used, but that's always a good one to know. So those are the DOACs. Warfarin is, the evidence have shown that it is superior to any kind of direct oral anticoagulant for 2 significant indications: a valvular AFib. So if they have a mechanical valve or if they have mitral stenosis that's caused their AFib, it should be the drug that you give. It's just been shown to be more efficacious, reduce the risk of embolic complications. And if you have a mechanical valve without any other kind of indications, it's just the only one that we know should be indicated for these potential risks to reduce the incidences of embolic complications. So mechanical heart valve and then valvular AFib is always going to be the first line for warfarin. If they have AFib, but it's not valvular, they don't have a mechanical valve, they have DVT, PE, anything else, DOACs are always going to be the first line.
And if I could recall from our previous conversations, I remembered that DOACs are actually a little bit more costly than warfarin.
So yeah, and I think it's kind of just depends on the patient, right? So warfarin definitely is cheaper, and insurances are son of a guns, you motherfuckers, But so I think sometimes your insurance may only allow you to get warfarin. So it kind of just depends. I've had a couple of patients where they wouldn't give DOACs, and unfortunately you have to get warfarin.
How do you manage supertherapeutic INR?
So when a patient takes warfarin, that's the downside. You have to close monitoring. DOACs are nice. You don't have to monitor those things, right? So you just take it and then you go about your day, right? You don't have to have them come in and get their blood checked every so often to see if they're within range. And there's not as much drug interactions and food. Like, you got to be careful with eating like vegetables and stuff, like leafy greens with warfarin. So it's like, man,
You eat a salad and you're done.
yeah, I know. Eat a salad, down you go, 6 feet under. You know what I mean? That's not good. So I think it's really important to emphasize the benefit of DOACs in that scenario. But warfarin, INRs checks are important to make sure that you're keeping an eye on. So if a patient has an elevated INR, but they are asymptomatic, that's a completely different treatment. If a patient has an elevated INR and they're bleeding. So it is different. So if their INR is, I like to say, I like 5 to 10. So if it's anywhere between like 5 to 10, what I'll do is I'll hold the warfarin for maybe a couple doses, and I'll give them a dose of vitamin K, usually oral vitamin K, not IV vitamin K. And some people may hate that statement. If you're in the ICU, I'm giving you IV vitamin K in true reality, but the guidelines say you give oral vitamin K. Usually it's like 2.5 milligrams.
Now our patient's 4.5 here for their INR.
Yeah, so I probably wouldn't give them anything. I'd probably I'd probably hold the warfarin, and then I would go ahead and just say, okay, hold the warfarin. Let's recheck and see if it starts coming down.
But we don't need the oral vitamin K yet.
We don't need it. Yeah. So oftentimes I like less than 5. Some will be a little bit more stringent, like 4 or something like that, 4.5. But less than 5, hold the warfarin and just don't do anything. You don't have to give any vitamin K. It should come down on its own. If it doesn't, you can consider it, but I'd say it's going to come down on its own with holding some doses. If it's greater than 5, like 5 to 10, hold the warfarin doses, and then I would give them a small dose of oral vitamin K, probably 2.5. In clinical reality, I'm giving them IV. But and then if you are INR greater than 10, then you're going to be holding the warfarin doses for a while, and then you give them a 5 milligram PO dose of vitamin K. But I'm giving them IV 10 milligrams. So that's kind of the differences there. But bleeding is a completely different story. So if they came in, they're peeing blood. They got a GI bleed. They have hemorrhagic shock. They got a bleed in the brain or something like that. It's 2 things: IV vitamin K, which I'm going to give no matter what. For INR that's elevated or bleeding. And then you have to, so the benefit of vitamin K is that it's going to go into your circulation, hit the liver, and tell the liver, let's turn on the synthesis. Let's kind of really amp up the synthesis of factors 2, 7, 9, and 10 so that you can actually help to clot, to stop the bleeding. But that takes time. It may take about 12, 24 hours for it to start working. So what am I supposed to do in the meantime? Just let them continue to bleed?
Yeah, just good luck.
Yeah. So I got to give something to get into the circulation right away to beef up their factors 2, 7, 9, 10, to give them time until the vitamin K kicks in.
Yeah.
So that's where we'll give PCC.
Okay.
4-factor PCC, Kcentra, that's the names of it, and it's factors 2, 7, 9, 10. So you're replacing what the vitamin K or the warfarin is actually inhibiting.
So that's kind of your own. That's a way of bridging.
Yep. Yeah. Exactly.
Now, on the discussion of bridging, when we initiate warfarin, why do practitioners have to bridge with heparin from the start?
I don't see this too often, but I think when I first started as a practitioner, you bring it up in rounds. Oh, we should really keep them on heparin before we start the warfarin, because we would just start warfarin sometimes without having that bridge. But I think, and the reason why is the warfarin-induced skin necrosis. It really only happens in patients who have like protein C or protein S deficiency.
So that's what you're worried about.
Yeah, like if they have that, you give them warfarin. They're already low in protein C and S, and so you give them warfarin, you'll inhibit factors 2, 7, 9, 10, so they won't be able to make those to actually clot, to actually help you to form a clot. And then on top of that, you'll have less protein C and protein S. And protein C and protein S, those are anticoagulants. And so if you have less of those, you're going to be a little bit more hypercoagulable for a couple days. And so you can get like skin necrosis. And so that's really the risk of doing it. And you don't know if somebody has protein C and S deficiency. But ideally, yes, you should put them on IV heparin for about 4 to 5 days, get them therapeutic. And then what you do is you start the warfarin, and then the warfarin will help them to kind of like get through. When you do that, you kind of allow for the heparin to give that coverage until you get through the procoagulable state or the hypercoagulable state during the first couple of days of warfarin. And then after that happens, then you'll go into that kind of like anticoagulant state.
And you're really providing this textbook, but this doesn't always happen.
Yeah, in the clinical reality, we don't always do it. But yeah, you should do heparin and warfarin, get them kind of therapeutic, and then cut the heparin.
If you had to say some common drug interactions with warfarin, what are the biggest ones?
Yeah, that's why you gotta be careful, man. So I hate warfarin, to be honest with you. Sorry. it just causes bleed, there's drug interactions, patients gotta go get monitored. I mean, I get it though, you take what you need to get the job done, but
Sure.
You gotta be careful when you take other drugs, because warfarin's metabolized by the cytochrome P450 system, like clopidogrel. And so if you take other drugs that actually go and work with this enzyme, you could potentially inhibit the enzyme. And so you can have what's called inhibitors or inducers. And so, for example, if a patient like this, they're taking Bactrim.
Yeah, good. He's on it.
Yeah, they're taking it for a UTI.
Poor guy.
Yeah, and guess what? Bactrim can act as an inhibitor. And so then what happens is when you have this cytochrome P450, it basically metabolizes warfarin to the inactive state. If you inhibit that enzyme, it's not going to convert the warfarin to the inactive state. What's it going to be in? It's going to be in a hyperactive state or in a higher active state, and then they're going to end up bleeding. So their INR could go up, right? And if you use an inducer, those are basically going to activate the enzyme and inactivate warfarin, you end up with less therapeutic levels, and then you clot. So it's like, you got to be careful. And so those ones you got to watch out for, like rifampin and like phenytoin. There's a bunch of them. There's like mnemonics out there to remember like which ones are inhibitors and inducers. And it's really important to remember that when you're giving a patient, you should go through the medication list if you're going to put them on something and say, oh, you're on warfarin. Let me make sure that I don't have any interactions with this one, and then consider an alternative. So.
And while you're not the biggest fan of warfarin, it really is super like it's just way more ideal in a patient with a mechanical valve.
That's why, like in certain scenarios, you have no choice, man. You got to do what's going to actually prevent them from developing embolic complications like mechanical heart valves and valvular AFib. Yeah.
It's pretty interesting.
Yeah.
All right, last case. Let's finish up here with case 6.
Okay.
We have a 68-year-old female presenting with sudden onset left-sided weakness and slurred speech. Symptoms began 2 hours ago. CT of the head is negative for hemorrhage. A couple questions for you, Zach. When is TPA indicated for an ischemic stroke?
Yeah, so in training, the providers would always kind of say, really, you just need 3 kind of inclusion criteria indications. One is a neurodeficit, right? And you monitor that via the NIH stroke scale. So, if you have at least even a point, you should probably give TPA. But any kind of neurodeficits, this patient has left-sided weakness and slurred speech. So depending upon that, their NIH stroke scale could at least easily be over 6. Second thing is they have no hemorrhage, no kind of like intracranial complication. So if I got a bleed in there, like a subarachnoid or an intracerebral hemorrhage or something like that, if I give them TPA, dude,
you're done.
This thing's gonna blossom.
Yeah. You're going to help them right to the grave.
Yeah, exactly. So that's the whole point of preventing those things. And then the third thing is within the window. And so less than 3 hours is the ideal, but you can go to 4.5 hours. They're actually starting to extend it out. So they used to say you could do it for like the higher risk patients. You could maybe go out to 4.5 and stuff. But I think generally, as long as it's less than 4.5 hours from their last known well, you can give TPA.
Okay.
Just you got to go through the contract, and obviously there's always these things that the person who's going to administer the TPA, the neurology resident or whoever it may be, they have to go through a checklist and say, okay, is their blood pressure here? Do they have no intracranial hemorrhage? Have you not have surgery within the past so amount of time? Or have you had a bleed in a certain amount of months? Have you had any kind of spinal or closed surgery in the past months? Do you have thrombocytopenia? Did you take any anticoagulants or anything like that lately? And if you go through that list and they have no absolute or relative contraindications, hit them with the TPA. Yeah.
How is intracranial hemorrhage after TPA managed?
Yeah, so I've seen this unfortunately a lot.
How?
Yeah, I mean, I think it was 6%. There's a 6% risk of developing intracranial hemorrhage after TPA.
Okay.
And so that's pretty decent. That's a pretty decent risk. And so you have to always like let your patients know that like, hey, this is designed to bust the clot, as we would say, because the thrombolytic is the only. So antiplatelets and anticoagulants prevent the clot propagation. thrombolytics like TPA, that puppy activates plasminogen, turns it into plasmin. Plasmin breaks down the fibrin mesh. You're literally going to break a clot up. So when you do that, you have to tell them, hey, there is a risk. It's about a 6% risk of developing intracranial bleeding. And so if that happens, and I've seen it unfortunately a couple times, you have to go ahead and check their, I like to check their fibrinogen level and see if it's low. So if it's like less than 150, I give them TXA. Even if they bleed, regardless, I'm giving them TXA. So if there's a bleed there, you can check the fibrinogen, give them TXA. If the fibrinogen is less than 150, I add in cryoprecipitate. So that's what I do. Because I had a couple of patients, got TPA. Yeah. Within a couple hours, a couple of them, oh man, terrible headache all of a sudden. Some of them just worsening, like they less responsive, worsening neurodeficits, and I was like, all right, that's weird. Send them to CT scan, boom, you got bleeds. Yeah. So then you hit them with TXA to stop the continuous action of TPA, which is not very long. It actually has a pretty short half-life. But you just can inhibit that fibrinolytic activity, and you give cryoprecipitate. And cryoprecipitate, if the fibrinogen is less than 150, that means it's really low. You give them cryoprecipitate to up their fibrinogen, and that will help to actually prevent them from continuing to have all these this bleeding. So those are the things I would do if a patient has bleeding after TPA. And that's the thing, TPA is used for not a lot of indications when it comes down to it. Like anticoagulants, DVT, PE, AFib, mechanical heart valve, and acute coronary syndrome. Antiplatelets, really, it's just like atherosclerotic cardiovascular disease and acute coronary syndrome, and that's really what it comes down to in stents. But thrombolytics, it's really just you have a PE that's killing you. Like you got a PE that's putting you into cardiogenic shock. You got a stroke. Those are really the only true indications. We can do it in STEMIs if a patient is not near a PCI capable facility, but it's really when it comes down to it, it's truly just like it's for stroke and it's for a big PE. And that's really what it comes down to.
Well, we covered 6 cases.
Yeah.
We finished up with antiplatelets, anticoagulants, thrombolytics. Hopefully you all learned a lot through this one.
Yeah, I think this was a fracking beast one. I like this one. This one was cool. I think it was kind of like a nice little approach to, pharmacology, but in a way of saying how is it applicable to a case, which was kind of cool.
I thought you were crazy when you're going to try and put all these things together. And it ended up working out well.
Yeah, dude, this is a good one. This was a fun one, man.
Awesome. Yeah, it was really interesting.
Yeah, thanks. So I hope you guys liked it. I hope that you enjoyed it as much as me and Rob did presenting it. And so, thank you guys for taking the time to listen to us today and to enjoy this podcast with us today. And I love you guys. Thank you guys. And as always, till next time.